for indebtedness in Singapore: number 1, overspending; number 2, job-related; and number 3, actually medical. So it's true, you will not be denied, but you're going to have that cloud of debt and bankruptcy hanging over you. And we believe that nobody should have to go bankrupt because of healthcare. Okay, again, a caricature from my friend Chu. How would you settle the rest of the bills? By cash, by check, by credit card, by selling your house, by selling your kidney? Hope not. So the other consequence of this system, okay, like I said, it protects you. It's from a catastrophic situation, but it results in hospital centricity, which results in overcrowding, unequal access to care, and inequities in public health care. Again, this is an article written in the Straits Times by Professor Lee Wei Ling, where she describes a friend who was admitted to one of the public hospitals, not the one that she's in charge of. And she said that this person never saw the consultant in charge until she wrote a note putting her name and handphone number. The minute the doctor saw the note, he telephoned the head of department. My friend had never seen or heard that person before. Other doctors asked, who are you and how are you related to Professor Lee Wei Ling? An hour later, the head of department called up, gave her the details, sent a bouquet of flowers from the hospital, and a senior doctor took care of the friend's husband and performed every operation on him personally. So it's really sad that in public hospitals, apart from the NNI, the people who are in the C-class wards do not get the same kind of care. And this has resulted in unsustainable healthcare cost inflation. Again, this is data from Dr. Lim Pin Min, who recently passed away, where he showed that what has happened is that healthcare expenditure has gone up tremendously, but the genius of the Singapore system is government expenditure has not gone up at the same rate that private expenditure has gone up. And this continues. Even just recently, we see that it's going up by about 11% a year. So we need a new healthcare plan, one that's affordable, sustainable, and universal. So the key features of this plan: larger government contribution, increasing in government spending, and we think that this can be done through many ways, through small taxes, through shifting the burden of expenditure. And again, I've got nothing against MINDEF. I'm, as you know, a volunteer with MINDEF. I get awards from people there. But it's actually going back to where we were. In 1965, as you heard, Singapore spent 50% of its, 50% of healthcare financing came from the government. All we need to do is just go back. That didn't have any adverse effect. The fastest growth in Singapore was in the late 1960s. And that was when the government was spending 40–50% on healthcare. So it is possible to do this. We want to avoid the American model, as everyone here seems to be saying, where America actually has got very low government contribution to public healthcare. So we propose a single-payer universal healthcare system, which will be run along the lines of a government-subsidized public insurance system to finance compulsory basic health insurance. We want to get rid of the 3Ms and have a simple system, which is a single, the current 3M system is very difficult to navigate. So it'll have a fixed premium for Singaporeans, for PRs a slight bit more. It'll be income adjusted so that those who are poor will be subsidized. Older people who are not working do not pay, and we share the cost. It's a compulsory system. As Kai Hong has pointed out, once you allow people to opt out, then you're going to run into trouble because you're going to have all this adverse selection. People are not going to buy insurance until they really need it. So there will have to be an additional safety net for the poor. There'll be a healthcare benefits card. And again, I'm running out of time, so I'm going to have to cut through some of these. So what we're going to do is, in addition to that, because it's a single insurance system, and rather than a complex mix of systems, there will be a strong regulatory framework. And believe me, Singapore is really good at regulatory frameworks. Okay, if any of you have tried to buy anything or to sell anything, you know how complicated it is. So we want to return the Singapore Medical Association guideline of fees, single-class wards, eliminate hotel services. Skip through that. And the other thing is stepping up the use of IT, a health benefit staff smart card that can be used both in the public and the private sector. So breaking down the walls between the public and private sector, which is actually one of the major concerns in Singapore. There's always been this distrust between what the, people feel that the GPs cannot be trusted. But if the GPs cannot be trusted, then, there's really no way that we can do anything about it. So reinforcing intermediate and long-term care facilities. The other issue is this problem of a hospital-centric approach. Last minute, I promise you. Okay. So, you've heard about how, as Kai Hong has explained, there's this big gap in this chart as to how healthcare works. And the issue is that we have good hospitals, we have good public hospitals, but the trouble is that the government does not provide any nursing home facilities at all. They depend on the VWO sector. And it's very, very difficult to do that. The result of which, again, this is from Straits Times, where they pointed out that 7 to 10% of patients in hospitals could be discharged, but there's simply no nursing home beds for them. So in summary, what this plan involves: larger government contribution, public health insurance system, evidence-based regulation of insurance payments, co-payment with caps for outpatient and inpatient care, and responsive long-term care at the point of need. Thank you.
Oh. Thank you very much, Paul. I think what I will do is to allow the 4 speakers to now comment on each other's presentation, to ask each other questions for the next 10 minutes, and then I'll open it up to the audience. So would anybody like to make a comment or ask a question? Kyle?
When we embarked on the National Health Plan, we actually did a lot of comparative research. That's why it became a lifelong passion even for myself, having worked in the Ministry of Health. And actually we have studied many of these different alternative types of financing before we embark on a savings-based model. And I must say that actually it's very easy to say, oh, we're going to have a perfect system, we're going to have, a one-size-fits-all and a magic bullet solution. And like what was said, there's no perfect situation. So what we have done is, when we decided to move away from a predominantly tax-based system towards a diversified system, it's not that the different parts of it is not working. It's just that the efficiency in terms of allocation, the allocative efficiency is not there because of all the vested interest that builds up. Either you have too much gaming of the system, or too much cost recovery, for example, or too little, or the rules were not adjusted fast enough, to keep up with inflation. I think part of the problem is that if you had fine-tuned or adjust the system as you move along, one of my biggest contention is that if the system keeps itself with inflation, some healthcare system in fact index the government share to inflation. If there's inflation, then government will maintain that proportion. That has not been done for the Singapore system. I think if that was done, I think your basic problem is solved. The second issue is, how much does government want to spend on healthcare? And it's a fundamental question. The world over, right, you can spend anywhere for a developed country from 10 to 18%. But in Singapore, we were obsessed with the thing about cost containment. We superficially kept it down below 3% until SARS came along, then it became 4%. And we are still obsessed with cost recovery and making sure the government share is kept at about 1%. So I don't see why we have to do that. I think that's, to me, is the biggest and fundamental problem. The other aspects of funding old age and all that, it's the same all over the world. It's something that no system has already solved. So I don't see how we can solve it by saying that, oh, we come up with a single payer system with strong regulation. You still have, whatever government you have, you still have to then decide who's going to pay how much.
Yeah. Pin Min, do you have a comment on what Paul has put forward?
Well, I think fundamentally all of us are trying to achieve a few objectives. One is to provide good quality of care to Singaporeans. Secondly, to make it as affordable as possible, and of course accessible to every Singaporean. I think the approach may be different, but not necessarily one is right or the other is wrong. My personal view is that the 3M system, the 3M framework still works. But there's a lot of refinement and adjustment as you move along. Like what Professor Phua has mentioned, the medical inflation has sort of caught up too quickly. And I think MOH will really need to review some of the restrictions that have been imposed on the use of MediSave, and also make the payout, in some of the insurances a little bit bigger so they can cover as much of the cost as possible.
I was surprised that, I've never heard this number before. I was surprised that the 3 M's together account for only 15%, 1/5 of total healthcare costs. I thought it was 50, but it's 15, which means that the rest is being absorbed either by individuals or by companies, right, employers. Huh? So let me ask Pin Min to make a direct comment on a statement made by a dear friend of mine who's passed away. I remember that when Dr. Balaji Sadasivan was alive and was suffering from cancer, colon cancer. He said that in Singapore today,